Sí.
A ver, testing. Kak depende. Đúng rồi, nó bị change rồi depende.
Dan tuan-tuan, sesi CME kita akan bermula sebentar lagi. Mohon semua mengambil tempat duduk masing-masing dan mohon kerjasama untuk memerlukan tempat duduk kosong di bahagian hadapan dan pastikan telefon bimbit anda berada dalam mod senyap. Untuk harian, sila impas kod QR yang dipaparkan di skrin. Kod QR juga tersedia di kedua-dua belah pintu dan pintu auditorium.
Kalau link terlambat. Tak apa mula-mula. Baik. Ajak kali mula-mula lambat nak tulis link. Tarik ni Hrpzii. Ambil link. Ada. CME Hrpzii. Dia. Okey. Dia. Ambil link ni. Share. Gitu. Kalau lambat saya atas buat link WhatsApp ke apa. Lepas tu boleh ambil link nak share ke apa.
Okay.
Baik.
Ini berlipat Sri Pinang, Sri dari Pulau Mutiara, pemanis kata selamat datang awal bismillah, pembuka bicara. Yang berbahagia Dr. Isamin bin Idris, pengarah Hospital Raja Perempuan Zainab II. Yang berbahagia Dr. Nurhana binti Muhammad Fazil, Timbalan Pengarah Perubatan Hospital Raja Perempuan Zainab II. Ketua Jabatan Pakar-Pakar Pegawai Perubatan, Paramedik dan seluruh kaki tangan Hrpzii 2 yang dihormati. Pertama sekali, saya ingin mengucapkan terima kasih kepada semua kerana meluangkan masa bagi sesi CME kita pada hari ini. Saya Nur Syadilah Farhah binti Muhammad Sani dari Jabatan Anestesiologi dan Unit Lawatan Rapi Hospital Raja Perempuan II akan menjadi pengacara majlis anda pada hari ini. Tanpa melengahkan masa lagi, saya menjemput yang berbahagia Dr. Murni Hartini binti Jais, pakar patologi untuk menyampaikan CME kita dengan tajuk Beyond the Lights, Untangling Dilemmas. Dipersilakan.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh and a very good morning. Today I'm Dr. Muni. I'm an anatomy-pathologist in Hrpzii since 2018. So I have just completed my AOI training in renal pathology last year July. So today I choose this topic because we are just to start EM service for renal biopsies. So I hope this topic can at least give you some ideas what are EM in the role of EM in renal biopsies. So this is the outline of my presentation. First of all, I would like to introduce what is anatomic pathology, what we are doing, who we are, and how we progress. renal pathology service as in global and local setting. What is EM, electron microscopy, and the dilemmas that we have in Malaysia as a renal pathologist, and the role of EM in renal biopsy, and what we have for EM service in Malaysia. So as we know, pathology is a study of disease. We have chemical pathology that involve measurements of the various chemicals and biomarkers, which include glucose, electrolytes, and enzymes. So we also have microbiology, which deal in detection of the infective agents like bacteria, viruses, or fungal and parasites. We also have hematopathology, which mainly deal with the blood disorders. And last but not least, we have anatomy pathology. So what is anatomy pathology? We are actually dealing with specimens involve histopathology and cytopathology. So for histopathology, we can widely divide the specimens into surgical related specimens and medical related biopsies. That's surgical related specimens, like mastectomy, stapso. We mainly focus on diagnosing the tumor, give the typing of the tumor, grading the tumor, and as well as staging, and give the information about the margin status, lymph node involvement or metastasis. Apart from that, we also deal with medical related biopsies, like skin biopsies, GIT, lung, liver, and of course renal. And this type of biopsies, we usually need more of clinical information for us to guide us to give the diagnosis, or at least morphology description of the disease. Apart from that, we also see cytopathology specimens, which include anything that involves specimen for cytology evaluation, be it gynecology specimen like pap smear, non-gyne, and FNAC. So currently we have in Hrpzii, we have 11 of us. Five have undergone areas of interest, and one is still in training. So it's quite a tremendous progress among us. And what we do is, the ultimate goal is to get the correct diagnosis to help the clinician in terms of management, treatment, and prognosis for better patient care. So anatomic pathology involves the whole body system from head to toe. So we have to see all the specimens, but it cannot be mastered in all. So we have this area of interest for anatomic pathology. We didn't call it specialty because after we have AOI, we still see other sort of specimens apart from our AOI. But when our colleagues were not sure of something regarding to the system, we will refer to the AOI specialist. So who we are, we have Dr. Amiza Hassan, who is AOI in pulmonary pathology. Work close contact with Dr. Zuki and the RSP team. And we have Dr. Hayati Yunus, who is head OOI in cytopathology. Dr. Afif, actively involved with Mr. Sola and the sarcoma team. We also have Dr. Zubaida in AOI, hematolymphoid pathology, and myself in renal pathology. And last but not least, Dr. Hafiz is still will be finishing in July this year. So I would like to also take this opportunity to tell you about the renal pathology service that we have. Before that, I would like to give you an idea what is renal biopsy. This is how we take renal biopsy, especially in supine position, we are aiming to the kidney via ultrasound guided. So renal biopsy should aim the cortex of the kidney because usually the indication for renal biopsy is to detect glomerulonephritis, which mainly we want to see the glom. So the glom is present at the cortex of the kidney. But we also have to make sure that we get the corticomedullary junction because some of the disease process starts at the junction. So this is how a renal biopsy, it's a strip of tissue. So ideally it should be 2 cores, and each core should be divided. Each core, because we we need the integration of like microscopy, immunofluorescence, and EM. So we have to divide the core and put them in different fixative to send it separately. So this is the guidelines on how to divide the specimen for the clinician. There's different practice. Sometimes the specimen was sent fresh to the hospital, and the pathologist will divide the specimen based on the dissecting microscope. But in Malaysia, it is not feasible to do that because like in our setting, the biopsy was done in hospital Pasimas. So we cannot send a sample fresh. I mean, within 1 hour should be sent to the lab. So in Malaysia, the specimen will be divided by clinician. So I would like to see linear biopsy like solving a puzzle. Before that, glomerulus is a complex structure. It's a 3D ball structure, which involve infiltration of the molecules. So if there is some injury to the basement membrane, it will be affected as kidney disease. So this is a cross section of a glom. You can see how complicated it is. There's a few types of cells there. And so we have to see all this under the microscope. So like linear biopsy is like solving a puzzle. I said this because we cannot diagnose something in the linear biopsy based on the morphology only. We need to correlate with the clinical symptoms, the family history, the serology markers, the virus screening, the urine FME or the urine 24-hour urine protein, and albumin level, as well as creatinine levels. Then only we come to the biopsies, which should have like microscopy, special stains, immunofluorescence, and last but not least, EM. But of course, in Malaysia, this is still not a well-established things can be done because this is just a dream in pathologists, renal pathologists in Malaysia. So it has been said that epidemiology and pathology of kidney disease is still unknown in large parts of the world because that's why we still have high rates of chronic kidney disease. People say that this because it's our inability to adequately process and interpret kidney biopsies. So the ideal thing should be integration of blood microscopy, IF and EM, as well as clinical and other lab findings to help to give a good prognostic information and guide the patient management. So this is our 31st report on Malaysian dialysis and transplant registry. It is very worrying. You can see the progress of chronic kidney disease that patient needs hemodialysis or peritoneal and transplant for the past 50 years. It's increasing and increasing. So let's see how's the practice worldwide. I'm sorry, this is a bit small, but I want you to focus at how we're doing here. This is a survey of, this is a question survey that was done in 63 countries in the last 5 years. They want to see how the practice of linear biopsy interpretation in all over the world. You can see Malaysia here. It only relies on the light microscopy and IF, most of our findings. So of course, it's not an ideal setting. You can compare with other upper middle income countries like South Africa. They did EM in almost 90% of their cases. But of course, this is not applicable in here. But at least we should compare with our neighbor, like Singapore and Brunei, which they did EM is in about 40% of the cases. So what are the setting of linear pathology service in Malaysia? We have also progressed tremendously in terms of AOI training. We have currently we have a total of 235 AP throughout Malaysia. 60 more than 60 of us have AOI, and AOI in pathology about 11 of us. We have in each state currently 4 in the Klang Valley, which also covers Negeri Sembilan and Melaka, Johor, Pahang. I'm covering Kelantan and Terengganu, and 1 in Sarawak. Because of we lack of full facilities to interpret the biopsy, we always gather. Recently, we formed a renal pathology special interest group, PSIG, under Academy of Pathology, so that we can always meet up and share difficult cases regularly. We meet up virtually as well. Okay. We also have the pictures at the back. We also have virtual meeting with our professor in Boston University, because one of us did manage to get a mentorship program with him for the past few years. Okay. How about the renal pathology service in Hrpzii? It is a good progress. We start to process renal biopsy since July 2022. After we sent a few of our staff for training, and also did attachment. But that time we only see native, we only process the native renal biopsy. There I underwent my AMR training. So since that, we have seen some increment in the renal biopsy sent to the lab for the past few years. And starting after I finished my training, we also process renal allograft biopsies. Of course, it's not that many here, but it is still important, because in renal allograft, usually they did the first transplant in HKL or Heslayan. Then after they are stable, few months, they will come back to their own respective states. Like for those in Kelantan, we come back to Kelantan. So the follow-up biopsies will be done here. Before this, we also send the sample to Kuantan, HTA. So there will be delay in management of the patients. So starting this year, we also have optimized our IF paraffin. IF paraffin is when we do IF study, but on the paraffin embedded tissue. Because most of the time, tissue sent for IF always no glom. So it's difficult for us to integrate the findings with the microscopy. And we also have start to collaborate with the microscopy unit in NIH for EM service, in which they are willing to process our sample, and they will produce an image of EM and send to me for interpretation. Okay, what is EM? So this is the earliest EM produced back in 1930s. It is found out by these two scientists from Berlin, and they find out that apart from seeing image under light microscopy, we can also see much more detailed findings using electron. So this is how the EM looks, the EM microscope looks like. The latest edition. It is a big microscope if you compare to the light microscopic that we have in lab. So there's two types of EM: transmission electron microscopy and surface electron microscopy, which is found 10 years after the EM. So what are the differences between these two EM? Transmission electron microscopy is when the sample is put at the center, and the electron is transmitted to the sample to produce image. So SEM is when the sample is at the bottom, and the image is produced based on the one that there was scattered electron, the reflection of this electron from the image. So the mission is a bit different, because the EM is much more complex, dia lagi panjang lah, and the ECM tu macam smaller bit. And the image that produced also different, because the EM is just imagine like you potong cake, the slice, the cut section of the cake, you can see the whole thing inside that. So this is one hypodermic loop of a glom. This is porocytes, this is the basement membrane, and this is the fenestrated endothelial lining. So and then SEM is much nicer. I think the image is much nicer. Tak boleh lah macam ni. We can see the whole, macam kita tengok cake tu from outside. The frosting and everything. This is the podocytes. So this is actually glom, podocyte, and these are all the food processors. Kalau macam virus, usually SEM lah. So in rhinovirus we use TEM. TEM is a conventional method, but it's still useful because although we have development of the molecular genetic diseases and genetic testing, but to see the ultrastructure of the tissue, the cells, we still need EM. So although it's an old method, but it's still relevant. So it involves in diagnosing certain fields like renal diseases, ni macam neuromuscular disease, like you have to see the pathology of the muscle fiber, microbiology in terms of biology, because virus is very small, and also a metabolic storage disease. You want to see the lysosomes of the cells and abnormality of the cilia, which this one cannot be detected on genetic testing. So what's the difference between light microscope and electron microscope? So as I mentioned, light microscope use lights, but electron microscope use electron as the beam. So light microscope is less resolution as compared to like electron microscope. So because it's only can see the at the level of the you cannot see the detail of the cells. But the limitations of electron microscope is a big microscope, and it will only produce black and white images. It's quite boring. So this is the difference. If you can see, this is a picture of one glom. This is one glom. It's composed of capillary loops, and this is the Bowman's space, and this is Bowman's capsule. But kalau electron microscope, it can only we have to see the whole glom, but this is a picture of this part only part of the capillary loop. We can see what happened to the basement membrane and the details of the cells inside it. Okay. This is another image of electron TEM. You can see one capillary loop here. This is podocyte food processes. This is one podocyte. This is the food processes. This is the endothelial cells. So this is the capillary loop. So we have to analyze everything here. And this is a normal glom. So I would like to address what are our dilemmas in pathology in Malaysia. My first dilemma is it looks normal, but of course it's not. So I would like to illustrate a case presentation. We have a 22-year-old gentleman which presented with hematuria and proteinuria since young. So the protein level is 44 grams, more than, up to the 40 range. The albumin not so low, fairly low, and the creatinine is quite okay. So what we see under the microscope, this is, just believe it, this is normal looking glom. Apart from this foam cells in the interstitium, it is common in any patient with nephrotic level of proteinuria. So we also, special stains also normal looking. But patient is symptomatic, but what we see is just normal. IF also not that helpful. None of them give any clue to anything. So for we sign out of monoglomerular changes, but it's actually not that normal. So there are a few diseases that can give this morphology. For example, diseases that only can be confirmed by EM, so like podocytopathy or type 4 collagen disease. And then diseases that are early in their process, like early membranous nephropathy, and maybe sampling issue, because there's one condition, FSGS, usually start at the junction, the corticomedullary junction. So what if the biopsy was taken there? So we might miss the disease. So these are the possible differentials for this patient at this moment. So, but particularly for this patient, we have further history. Patient has bilateral sensory hearing loss and quite significant family history of kidney disease, which he is a male. This is the patient. So both father and mother are healthy, but his first brother has been stage since 23 years old. The second brother also has the same problem like him. Same to the third brother. He is healthy. He's himself also not that healthy. So because of this, actually this case memang dah hantar EM lah. Because I just want to say in case we don't have EM for this case, so definitely we miss the diagnosis. So as I said, solving a puzzle, in this case, is a young male with hematuria and proteinuria with significant family history, so it's negative, value screening negative, level proteinuria, 1391, but the lab microscopy is just minor glomerular changes, and I have non-specific findings. Definitely we need EM to solve the puzzle. Okay, what's his EM looks like this. Kalau you can remember the normal one just now, it should be thin layer of basement membrane. But here, the basement membrane is thickened and laminated. The podocyte also very large. And the food processes are effaced in some areas. It should be like this, stand up, but it's effaced. So, but in other areas, the basement membrane is thin. This is another loop. This is one loop. So this is normal EM for capillary loop. You can compare these two images. So recently they have described that Alport syndrome, previously we thought it's a rare disease, but actually at molecular level, they find out that this is involved with genetic problem at the collagen type 4, which involve the alpha 3, alpha 4, and alpha 5 mutations. Those the typical X-linked, like this case is X-linked disease, is alpha 5 mutation, but they also find out that female also can have this problem with that have mutation in alpha 4 and alpha 3. So this collagen type 4 is found in kidney, ear, and eyes. So that's why the patient also have hearing loss problem. So what I want to see here is the alpha, those with alpha 4, alpha 3 mutation might just be demonstrated as thin basement membrane lesion, in which they won't have any nephrotic rich proteinuria. They just presented with microscopic hematuria. So according to my supervisor, because we have for EM, we also do for potential kidney donor in HKL. So she said a lot of Malaysian population have this condition, but we don't have the symptoms. So if we didn't do EM, we might miss this condition. So in this article, they also find out that for mutation, genetic disease in kidney, most 30% is polycystic kidney disease, and 30% is Alport syndrome. And out of this 30%, when they did the retrospective study, 60% have been misdiagnosed because patient might presented with SGS, hypertension, and other sort of symptoms. So let's see how we did in Malaysia. According to the 8th report of Linear Biopsy Registry 2022, I'm also puzzled with this registry because we stated that minimal change disease. This is only can be confirmed with EM actually, but according to the nephrology, most of them, when we diagnose minor glomerular changes, they take it as minimal change. Yes, it can be done like that if in the correct clinical settings, but not all microbial changes are minimal change disease. So it's quite a number of cases in Malaysia as labeled as minimal change disease. And they involve quite young age of patients. Those with less than 25 years old, about more than 50% of them has been labeled as minimal change disease. I want to see what are the implications if, in this case, if we don't have EM. So patient will be treated as minimal change disease, unsampled FSGS. So then, steroid when patient will not respond to steroid, so labeled as steroid resistant nephrotic syndrome. And ultimately, in Alport syndrome, patient memang akan progress to end stage. But they only just need, they really need transplant, and they only need symptomatic treatment with ACE inhibitor actually. So if we subject the patient under this diagnosis, they will be treated as unnecessary treatment with steroid. So of course, this is a waste of resources. And if we didn't do EM, of course, we don't know that the patient actually have family history of, significant family screening should be done. So what I want to convey that actually all microbial changes are minimal change disease. Of course, all minimal change disease will show microbial changes on laparoscopy, but not all microbial changes are minimal change disease. So only EM can resolve the dilemma. My second dilemma, we see it, but we don't know what it is. So this is another case I encountered during my training. This is a middle-aged man with underlying poorly controlled hypertension. Patient presented with proteinuria and high BP. Creatinine have been doubled up in the last 1 year. And he also noted to have dyslipidemia. So creatinine datang naik from 180 to almost 200 plus. Protein 4 plus, very high protein level, 9 grams per day. Albumin quite low, 27. And the cholesterol level is 7 with high TG and LDL. So what we see here, we see something in the lumen, but we don't know what it is. It is not immune deposit. It is not the typical what we usually see. So we just report what we see. We see something in the intracranial lumen, but we don't know what it is. So IF was not very helpful in this case. So like solving a puzzle in this case, is young man with proteinuria, no family history, serology negative, screening negative, significant proteinuria, high cholesterol level. We have some findings in the laparoscopy, but we don't know what it is. IF was non-specific. So EM, we need EM. This case, we did send EM. After a year, patient not responding to treatment, only they send another biopsy with EM. So we still see that thing inside the lumen. This is lipid. Only under EM you can see that it is lipid. So actually, patient is having hyperprotein glomerulopathy. If you compare the image, it's almost similar to our case, but we don't have EM to confirm the findings. So actually, patient just need lower lipid lowering agent. No need steroid. That's why it's not responding to steroid, because the treatment is not it is. So what is the role of EM in renal biopsy? Should we do EM for all our medical renal biopsies? Knowing that EM is an important component to diagnostic of renal biopsy, some of the studies said if we fail to do EM, we can result in an incorrect diagnosis with possible clinical consequences. They also suggest that maybe tissue should be stopped for EM, and if cannot proceed with EM in all cases, in the practice was done in international level. But this article also showed that EM is not that, EM is contributory in 20% of linear biopsy and crucial in 20%. So we want to tackle this 20%. But if you see the children population, EM is much more helpful in up to 70% of the cases. So I want to highlight here that not EM is not helpful and not used, no need in all cases. For example, that this case patient is nephrotic syndrome and symptoms, no family history, ANE positive, urinary FME, protein 1 plus, blood trace, virus screen negative, criteria normal, HPE still minor glomerular changes, but IMD full house. So with these findings, we obviously not EM. EM is just supportive. It helps in confirm diagnosis, but not that crucial because based on the findings that we have, we can also still diagnose lupus nephritis class 2 because of the RF findings. So let's come to my third dilemma. We want to offer EM service, but we don't have the facilities. If you remember back in 2013, we have been shocked by the news of IMR terbakar. This is, we say, it's blessedly discussed. At that time, we have EM, but the EM was very old version. And it's not poor and not properly maintained, so dia dah macam nak ber. So with this, because of the fire, we have a new building in NIH. So with that, we also get new asset together with EM. So this is in 2022, with Dr. Baba for officiate the EM service there. And here we are. Last year, I'm discussing cases with my supervisor and my colleagues. So after the new facilities, HKL managed to send some of the linear biopsies that need EM to the NIH. And we also did the same thing. We also asked their baik budi lah for us to send EM there. But they limit our case to only 3 cases per month. So this is my dilemma. I want to offer the service, but I have this limitation. And so I want to stress out that what are the indications for EM in linear biopsy, at least in Malaysia setting. So we have to choose what are the cases that we really need EM. So we can divide them into native kidney biopsies. This is very important, especially in patients that have steroid-resistant nephrotic syndrome. Patient nephrotic syndrome dah on steroid tapi tak respond. So we on repeat biopsy, it is highly recommended to send for EM. Patient with family history of liver disease, pediatric cases, of course, this is if you have pediatric cases, and it's not minimal change disease, you should send for EM. And of course, if patient have clinical history suggestive of Alport syndrome, so you should send for EM. This is optional, unexplained hematuria. This is what I told just now, thin basement membrane disease. This condition is not that harmful, but if you want to be a donor, it is worth to look for. So for transplant kidney biopsies, should select cases for EM in which when after transplant, patient having proteinuria again. And of course, for evaluation of potential kidney donor. So let's see how's the pattern of diseases that we have in Hrpzii for the past 2 years, 2023 and 2024. So most of our cases are mainly lupus nephritis. This is not indicated for EM. So we can focus on those diagnosed of minor glomerular changes, FSGS pattern, and transplant cases. So I think we can do it with that 3 cases per month by focusing on these particular conditions only. So I want to talk about a little bit on available EM service in universities in Malaysia. For KKM setting, we only have NIH, although it is mainly for research, but They are willing to help us for diagnostic purpose, but with limitations. We also have UPM, but this is with charge, and UKM. So this is the only free, unless patient can willing to pay, we can send to other settings. So come to our take-home messages. Interpretation of renal biopsy requires intervention of clinical lab investigation that involve utilization of microscopy, IF, and EM when necessary to solve the puzzle. So EM is indicated in podocytopathy when we want to see the problem of the podocytes, the GBM abnormalities, this type 4 collagen disease, pediatric cases, to identify hereditary glomerulonephritis and transplant cases with proteinuria. So last but not least is we have to make do with the facilities that we have to improve the diagnostic accuracy, particularly in renal-related diseases. That's all from me. Thank you. Okay, kalau tak ada soalan ke?
Pediatrician. So anyway, I manage patient pediatric with renal disease. Yeah. Usually, I didn't perform the renal biopsy. Usually, or renal biopsy, I transfer to USN. So and then everything interpretation from USN. But some case I didn't satisfy lah USN because they put me macam apa? Minimal change, but not respond much. So macam kalau USN, how would they ada deposit tak yang electron microscope or how to collaborate with USN?
Kalau you hantar USN, then USN nak hantar EM. You kena hantar melalui UKM atau UPM. So patient kena bayar. So kalau
I mean, I am example, slide tu istilah lagi yang slide dia kan?
different. Tadi macam saya cakap tu, the process tu different. The fixation is different. So memang tak boleh nak.
Macam second reading tak boleh macam biasa kita usually kan kita buat second opinion kan hantar.
Yes.
Tadi tak boleh lah.
Boleh hantar the slide we can evaluate for you, but then for EM tu memang tak boleh nak hantar lah. Different physician. Kena hantar from the start tu dia hantar this side. Kena buat essay kat sini. Buat essay kat sini boleh hantar ke to me. Any other question? Kalau tak ada question, saya nak tanya soalan lah. Let's see how you concentrate or not with my presentation. It is easy. Electron microscopy uses light as a source of energy. True or false? Angkat tangan. Cuma. False. Betul. They use electron as a light, as the source of energy. Okay, EM is indicated for all medical renal biopsies. True or false? False juga. Okay. Okay, this here panjang sikit lah. All are true except EM is crucial to diagnose type 4 collagen disease. EM is essential in the diagnosis of class 3 lupus nephritis. EM is mandatory in early membranous nephropathy. EM is important in diagnosing untransplant glomerulopathy. Mana yang salah?
Yang salah EM is essential in diagnosis of class 3 lupus nephritis.
Betul. Sebab this one you can diagnose without EM. So, okay, thank you for your participation. These are my references. Love your kidneys and they will love you back. Thank you.
Majlis merakamkan ucapan terima kasih kepada Dr. Hrpzii atas penyertaan yang sangat informatif kita ini. Majlis dengan ini menjemput dan mempersilakan Dr. Izamin bin Idris, pengarah Hospital Kepala Daerah 2, dijemput untuk ke pentas bagi menyampaikan